Hi, my name is Emmett Schuster, and today we'll be talking about CPT and HCPCS coding, also commonly known as HCPCS coding. First, a brief history. In 1965, President Lyndon B. Johnson created Medicare and Medicaid services. In the same year, the American Medical Association saw the need for common medical billing language. Basically, the AMA looked at everything and was just like, hey, it would be a really good idea if we were all on the same page about who was being billed and for what they were being billed about. Now, the creation of HIPAA further progressed the development, and we'll get into that later, but both CPT and HCPCS are for procedural reporting. So first off, we'll talk about CPT. CPT stands for Current Procedural Terminology, developed by the AMA in 1965, but was not published until the following year. It is a list of descriptive terms and numeric codes for medical services and procedures, and certain levels are considered part of HCPCS, but the CPT was created first. There are 3 levels. The first level is for medical services and procedures. And on your sheet, I have an example for you, that chart, which I'm sure you are all very familiar with those codes. Those codes are considered CPT codes. Level 2, I also have some examples for you. Usually these are patient history or physical examinations, and they are for evaluation and management of clinical services. The last level is for emerging technology. Usually they will use this level if they don't have a code for it yet, or it's a brand new technology out. HCPCS. So HCPCS stands for Healthcare Common Procedural Coding System, developed by the CMS in 1978 and made mandatory for reporting commercial insurers by HIPAA in 1996. Before that, it was optional if you wanted to report HCPCS or not. HCPCS are a set of codes that represent medical procedures, supplies, products, and services and used in health insurance claims by Medicare and related services. So there are 2 levels. The first level is very similar to CPT codes. Honestly, the CMS looked at CPT codes and decided, hey, these are really good, let's just roll them into our level 1 HCPCS codes. The differences were so minor, it was very hard for me to find when I was researching. But also, generally, HCPCS are for Medicare and Medicaid services. Generally, if you're not using Medicare and Medicaid, then you would generally use CPT codes. HCPCS level 2 are 5 characters long and start with a letter. These are for non-physician services and procedures. There are many different types, and I gave you an example. And I gave you some more examples on your paper as well. Let's talk about the national effect. So, CPT and HCPCS coding helped to categorize and organize billing for procedures and services rendered. It also grew with the help of HIPAA, CMS, and fee scheduling. It helped to not only grow hospitals, but also to help grow our profession as well, because it increased the demand for healthcare workers. The daily impact of physical therapists is it aided in the ease of reimbursement of physical therapy services and the organization of their billing systems. It just made things run a little smoother. Now, obviously, right away, it wasn't as smooth because physical therapists had to learn a new coding system that they may or may not be familiar with. Fee scheduling made reimbursements also uniform. So what fee scheduling is basically the CMS decided, hey, we've seen so many people with the same cases and they're all reimbursed different amounts. Wouldn't it be a great idea if we all made it the same? So basically what they did is they looked at a bunch of data, decided, okay, this is about the average amount of cost for somebody who had a stroke. So this is the amount that we're going to give to a hospital. Whether they use that full amount or not is on them. And we'll get into that a little bit here in a second. So certain codes had higher reimbursements depending on the case of each person and what is needed. Back to the fee scheduling that we just talked about. So one charge of therapeutic exercise was that amount, and one charge of neuromuscular re-ed is that amount in Indiana in a hospital from CMS services. Now, if you had a patient who was a stroke patient and you just did TheraX with them and no neuromuscular re-education, that fee schedule is a set amount. You're only going to get so much by charging just therapeutic exercise. If their case allows for them to do a charge like neuromuscular re-education, it would be a good idea to do that charge with them and then put it down for your reimbursement later. Otherwise, you're just leaving money on the table. And you can't just code for whatever you want, though, because if you code for neuromuscular re-education when all you did was TheraX, then you may be audited by CMS services. Now let's talk about the daily impact to the physical therapy profession. This introduced timed and untimed codes. A timed code would be like therapeutic exercise, neuromuscular reeducation, gait training. An untimed code are typically physical therapy evaluations, reevaluations, and that kind of thing. They follow the 8-minute rule, which is commonly known as, but the CMS calls it the 15-minute rule. And I have a nice chart on the back for you to follow along. So what that means is, every 15 minutes you can tally a charge down. But CMS realized, there is some wiggle room. It doesn't always take 15 minutes to do something. So they gave it 8 to 15 minute range. On your chart, it shows you the lowest level is 8. Now, and then it says 22. Well, what's 15 plus 7? 22. If it was 15 plus 8, then you would have 2 charges. But since you didn't hit that 8-minute mark and only got 7, you're still at just 1 charge. You can have more than 1 charge for a time code, but the reimbursement goes down with additional charges. Therapists now need to know what they are billing for and how much each charge is worth, and if that service is actually valid for the person they are seeing. And finally, we can talk about the impacts, especially at Blackford. The one-on-one rule with your Medicare patients requires you to be one-on-one with your patient. So that being said, Blackford did a great job with this. They just decided, hey, let's make everybody one-on-one, but that also kind of made your scheduling a bit more difficult to fit people in. It can also alter the course of financial planning, i.e. incorrect billing. You might get audited by CMS. Nobody wants that. Or you might lose money if you don't charge for the right things. And finally, you may need to hire another individual to make sure billing is correct, and also to make sure that, you also might need to hire another physical therapist just so you can handle the one-on-one and things like that. Any questions?